We're going to see now the thrombolytics medications. The thrombolytics aid in the conversion of plasminogen to plasmin. And remember that plasmin 1 destroys coagulation factors, destroys fibrinogen and thrombin or prothrombin. 3 decreases the aggregation of platelets. So here we want to overcome the action of the plasmin. We want the action of plasmin, that is, decrease the clotting, so is to dilute the clot. That's what we want when we give the thrombolytics. So we give this in acute event. And the acute events will be, for example, a myocardial infarction or a ischemic stroke before 3 hours in a young patient and less than 4.5 hours in a greater than 60 years of age patient. It could be that sometimes there are contraindications for giving thrombolytics, especially in stroke. When we think about stroke, the contraindications are extreme bleeding, so intracranial or recent intracranial bleeding due to trauma or surgery, for example, within 3 months. That there is increase in the pressure, so greater than 185 for the systolic blood pressure or greater than 110 for diastolic blood pressure. Transtorns of the glucose levels, so if there is less than 50 milligrams per deciliter of glucose or greater than 400 milligrams per deciliter, we don't give thrombolytics. If the patient is presenting with a seizure at the moment of the stroke, we don't give thrombolytics. If the patient has GI or urinary bleeding within 14 days, we don't give that. If we can correct, for example, the glucose level before the 3 hours, then we can consider to give the thrombolytic. But if we cannot correct it, we don't give it. The thrombolytic mechanism of action is sometimes they are clot specific and some are clot non-specific. That means if they bind to the fibrinogen or plasmin that is already in the clot or not. If they bind to the fibrinogen that is in the clot, only to that it's specific. If they bind to the fibrinogen that is in the blood and in the clot, then it is clot non-specific. The drugs are alteplase. Alteplase, abbreviation is A. Is TPA. Ralteplase, abbreviation is RPA, or tenecteplase. Tenecteplase, abbreviation TNKPA. TPA. Alteplase is the only one that is clot specific. Usually all can bind to fibrinogen that is in the blood and in the thrombi. There is also streptokinase. Streptokinase is a protein that is found on streptococci. We can give this, usually we give it many times because it has the same mechanism of action. Just the problem is if the patient recently had a streptococcal pharyngitis, for example, or infection with streptococcus, the antibodies can interact with these streptokinase that we are giving and so decrease the activity of streptokinase, and so they would have a lot of effect. Other issues that can produce allergic reactions or certainly some reactions because the patient was previously exposed to streptokinase in the previous infection or in the infection that had. The streptokinase can also produce hypotension. Sometimes we want to revert the action of these thrombolytics. When we need to do this, we can do it either by giving fresh frozen plasma that contains only coagulation factors, or prothrombin complex concentrate, only the vitamin K derived coagulation factors. So certainly we have thrombin, and from there we can activate the factor 1 fibrinogen to fibrin. That, and sometimes we can give tranexamic acid, because these ones blocks the conversion from plasminogen to plasmin. Now the thrombolytics are very effective in MIs or strokes. Usually they are not given on a transient ischemic attack, not at least on 6 months. And we need to be very careful on the timing that we can use them, and we need to know certainly the contraindications, when not to give them, and how we can revert the action of the thrombolytics if something has happened.